Welcome to Ventricular Rhythms. This section will be focusing on all electrical rhythms originating or having to do with what's below the AV junction. Quick reminder on the anatomy and physiology just to warm up. You of course have your four chambers, you have the atria up top and the ventricles below. Within those ventricles, the two items we're going to be most concerned about, other than the muscle itself, is going to be your bundle branches. We really won't be focusing on the bundle of His or the AV junction, those things. It's more of just the bundle branches and the ventricles themselves are we're going to be driving the rhythms that we'll talk about today. To just kind of recap or just give you a rough outline, for the basic arrhythmia folks, it's going to be pretty straightforward stuff with bundle branch, blocks, PVCs, V-Tach, and V-fib. Asystole and PEA. As for the advanced arrhythmia, they are going to learn about some extra items having to do with PVCs, V-Tach, as well as Idioventricular Rhythm and ventricular standstill. Right. And on we go. As promised, a deeper discussion into PVCs, and that's what we're discussing here. And what we're really going to go over is, can you tell if the PVC came from the left side of the heart or the right side of the heart? And I can honestly tell you, yeah, there's a number of clues you can pick up on that'll really help give you a strong indication of which side of the heart was responsible for generating that beat. And so here's how it works. First off, you have to use V1. That's the first thing. So we're not looking in lead 2, we're looking at V1. That makes sense because that is laying right in front of the heart and measuring any electricity coming out through those ventricles. In the case of a right ventricular PVC, you are going to have a deep S wave in V1. And that's what we have here in this case, is that it is RS. So tiny little R wave, massive S wave. And of course you have the majority of that QRS complex going down. Your T wave is facing the opposite direction. That's a sign of a right ventricular PVC right there. On the other side of the coin, for a left ventricular, you are going to have a tall R wave. And that's going to look just like what you see here. And one of those things that you hear people talk about a lot are the rabbit ears. And that's where you have R and some kind of R prime to go with that. And that's your quick indications to tell right versus left ectopy. At the end of the day, it's not like a true bundle branch block. You'll still want to have a 12-lead EKG or something like that to help give you more information regarding it. But handy to know. Which of the following statements regarding premature ventricular contractions, PVCs, is incorrect? So which of these is not true? PVCs may have a wide range of configurations, including but not limited to RS, capital Q, R, RR prime, QS. Well, that's actually very true, so we can take that one off the list. Multifocal PVCs occur when more than one location within the ventricles are irritable and creates ectopic beats. That's absolutely true. That's the definition of multifocal. C, a couplet of PVCs is technically also a run of PVCs. That is not true. A couplet is a couplet. You need 3 to be a run of PVCs. Now, which then leads us actually to D. A run of PVCs is technically also ventricular tachycardia. That is true. So out of all of these statements, C is the one that is not true. In basic arrhythmia, we walked through the simplistic view of V-Tach. Now that you've got that under your belt, let's talk about some of that higher end stuff that's really neat. So it is entirely possible to have ventricular tachycardia because technically it's anything that is greater than 100 beats per minute. And so some people can actually be in something called slow V-Tach, where you've got a rate less than 150. Now, typically, V-Tach is going to be here, which is 150 to 200 beats per minute. In cases where patients actually get going faster than 250, it's moving at such a rapid clip that it can actually be called ventricular flutter, not fib, flutter. There's another slide where I'll talk about that as we go forward, but it's kind of a neat concept. Is it going to change what you do? Not necessarily. You're still going to check for a pulse and do all those different patient support things that you would be expected to. So your regularity, nothing different there. You really won't see P waves. If somehow you manage to see them, it's because there's AV dissociation going on, and the QRS that's being produced during the V-Tach is just not being communicated. And so it's a lot like having a third degree block, that the ventricular stuff is not being conducted up to the atria, so the atria is just clipping along like it normally would. And so those P waves may sneak through. If you do see a PRI, it's going to be that same third degree heart block rules, that none of those P waves have anything to do with the QRSs. Wide and bizarre, like we would always expect. Additional things I want to talk about is sustained versus non-sustained V-Tach. So we'll just assume we're right here in the middle and that we've got the 3 greater than or equal to 3 PVCs rule. We've met that. Sustained and non-sustained. Sustained V-Tach is greater than 30 seconds or requires an intervention because they became symptomatic. So we had to shock them or give drugs or whatever. Non-sustained is less than 30 seconds, and the patient really has no symptoms. It's not a problem. It happens and goes away. And that's why that count is so important, that you say it's a run of 5, 10, 52. I hope you don't say that, but how many beats of V-Tach there are. Because if it's a full 20, 30 seconds, that very much changes the way things look as opposed to a 5-beat run of V-Tach. You know what I mean? And so that's the idea that we're trying to get, or that I'm trying to get across here, is that take the time to say, you know, this is sustained V-Tach, this is non-sustained. Using these words is going to help the physician or care provider that you're speaking with have a better understanding of what you saw on the strip. As part of the advanced arrhythmia, I'm going to bring it back around to the prolonged QT interval because it's really important when we talk about ventricular rhythms. And here's why. So prolonged QT interval can come about 2 different ways. You can have long QT syndrome, and that's inherited, and that's when certain drugs or medications will just rapidly put you into a prolonged QT state. More often what we would see is the acquired type, which is what tends to come through hospitals. What is the definition? Well, essentially it's when you have a QTC, so your rate corrected QT interval, that is greater than 500 milliseconds. And even then I would say you got to get up in the 600s sometimes to 700s, and the patient is still asymptomatic, but that means interventions need to be done. So always keep track of that QTC. If it's greater than 500, we need to figure out why. That's actually very valuable. Rhythms that are associated with this include a sinus bradycardia that you just maybe didn't notice that there was such a wide QT. There's also heart blocks that frequently go with this, and even pauses, which we kind of talked about in the previous section about heart blocks, that a pause isn't just a pause. We should dig in and figure out why. Drugs tend to be the biggest cause when we talk about the acquired, so here's just a couple of them to refresh your memory. You've got amiodarone, procanamide, which we don't really give much at our facility, but other ones may use it. Your antibiotics, which thanks to sepsis protocols we give plenty of, and that's Levaquin and erythromycin. And another one is azithromycin. Antipsychotics, haloperidol or Haldol, often give that for patients that may be delirious or things along that nature. And last but not least, there's antidepressants, and so SSRIs is a common group, and that can include citalopram, which is Celexa, or you could even be looking at Lexapro, any of these. And it's not usually just one, it's a compounded effect. So that your patient's on a heart medication, and then we start an antibiotic, and then maybe we give them a antipsychotic, or maybe they're on antidepressants and heart medications, and they start another antidepressant. Well, and then we give them antibiotics. You can see how the additive is what really may push them over the edge and put them in this state. And that's why we just need to keep an eye on them when we can, or that we do the 12 leads, maybe in a clinic scenario, anytime that there's major medication changes, just to make sure that we're not accidentally causing a secondary problem. The big reason why I'm going over all of this is that if this gets long enough, it will cause a very specific type of V-Tach known as torsades. TDP. And that's important, mostly just it's a nomenclature thing, but that's what most people really worry about, is that you prolong that QT interval and they could either flatten out into asystole or get torsades. As that T wave gets kind of stretched out, there's actually a tendency that sometimes they may go into asystole. A couple other things just to talk about what can cause this, because it's important. Any patients that are hypothermic, if you've got low magnesium, low calcium, and or low potassium. So alcoholics are a great one because they're just low on all of their electrolytes. That's another reason we have to be careful with dialysis patients, that we keep those electrolytes in line. And then, of course, intracranial pressures, or intracranial disease. And it's just a short list, but it's things that come across a lot of different hospitals and are things that you want to be aware of. Having just talked about the prolonged QT interval, I think this is a really good strip to talk about a few other things. Now, if you didn't catch the story on the last one, or during basic arrhythmia when you looked at this, and you can always go back and go through the whole analysis if you want, but this was on a comfort cares patients. We withdrew vasopressors and the ventilator, and obviously with the family's permission, and the patient passed away rather quickly within a handful of minutes. Once they stopped breathing, of course, no oxygen is being added to the blood supply, so slowly the body used that up, in particular the heart. And what happened was he had global cardiac ischemia, and so the entire heart just kind of died on its own. This is one of the rhythms that heart produced, and this is a polymorphic V-Tach. I don't think there's really much question about that. But in light of talking about prolonged QT interval and torsades, what really is that big difference? And so this is one of those great examples that if you have a pre-existing prolonged QT interval, I'll just call it a QTC, and you go into a polymorphic V-Tach, we're going to go ahead and call that torsades. TDP. Now, if you do not have that prolonged QT to start with, then we're going to wind up using this one here and say it's polymorphic. In fact, in most cases, the most common etiology is ischemia. So keep that in mind when you see it, that if it does pop up, you do see something that looks exactly like torsades, that's exactly the reason to treat the patient, assuming that there is a prolonged QTC issue potentially. So it's a good hint to have, just something to be really aware of going forward. Ultimately, you probably need a 12-lead ECG or 12-lead EKG to really figure out exactly what the situation is. In researching how to interpret this strip, I came across something really interesting, and it's the answer to why you see a couple of these beats. So it's actually like beat number 2, 4, 6, 11, and 13, why they look so different, what's going on. And it's this. If you measure these out, it's exactly 25 apart for these, 52 across this big gap, and then another 25. And so what it looks to be is that there is a second site that is actually ticking along at its own pace and is actually able to get some heartbeats out in addition to the V-Tach that's going on. And so that's really, really just interesting, the fact that that can happen. Now, is it potentially something that's being driven by a P wave? That, maybe the sinus node does fire and it just magically times out just right, that you get a normal beat on top of a V-Tach beat? Potentially. A lot more detail would be needed to figure that out from here. But I just really wanted you guys to realize that things like this can happen. That may explain why you see patterns within patterns, is that lots of really, really cool stuff can happen. But in this case, I think it's polymorphic V-Tach, but that there's a second site firing. And it may be a secondary V-Tach site that you've got polymorphic V-Tach because there's two locations going off at once. That was the big thing I just wanted to show you guys on this, is that really neat stuff like this does happen. as promised, what happens when you are in V-Tach, but your rate is up in the 250 to 300 range? Well, it's actually called ventricular flutter, but it does have a pretty specific pattern, which you can see on the screen, and I just want to walk through it. This strip is short, it's not a full 6 seconds long, but the criteria that we're going to look for is that the pulse is just, the rate is so fast that there's no pulse because there's not enough time for the ventricles to fill. You're not going to see any T waves, and there's not going to be any isoelectric line that you can possibly see, and no P waves. Which, just eyeballing this right here, we pretty much hit that criteria, but let's go ahead and walk through it. This is nice and regular. The two easiest beats to measure is going to be right here and here. And that is 5 small boxes, so we've got equals a rate of about 300. It is regular. There's no ectopy beyond the fact that it's an ectopic rhythm, and there's no pattern other than it's perfectly regular. There's no P's, no PRI. The QRS is uniform. I really can't tell you whether it's an RS or a QS. I'm probably going to go ahead and say it's a QS pattern. It's wide because we've got 5 times 0.04 equals 0.20. So it's wide, it's fast, it's uniform, there's no T waves, and that's pretty much what it takes to say that this is V flutter. Granted, this is looking through lead V1, but it's pretty much going to appear the same way everywhere. You just have this from one to the next, to the next, to the next, to the next, just like a flutter, where those P waves are constantly occurring one after the other. This is just happening in the ventricles instead. Is it going to change what you do? Absolutely not. This is 100% an ACLS situation where you need to do compressions and defibrillate, like always. For the advanced class, I think this is a perfect opportunity to take a moment and discuss a really tricky point, something I've run into many times, which is it V-Tach or SVT with aberrancy? Or maybe a bundle branch block, because that can occur as well. How do you tell the difference between those? They're both super fast, they've both got wide QRSs. Is there any wind to it? If you try and research this, it's very, very, very difficult to pin it down. At the end of the day, it really comes down to if there's a pulse, are they symptomatic? And, what's their level of consciousness? Their LOC, what do their vital signs look like? That's what drives this. And if you look at ACLS, the way it treats things is narrow complex, wide complex. Are they symptomatic, asymptomatic? And that's where you go with things. They're getting less and less hung up on exactly what's going on with the rhythm. But for us, if you have the time, it's important to be able to try and apply all these skills that you've been learning throughout the course. So let's walk through this. I've got a rate of 15-ish, although it's a short strip, so I can't use that. What I can do, though, is measure between, we'll just measure between 2 and 3. And that comes out to 9. And just in case I think it looks a little bit wider, I'm going to measure between 10 and 11. And that also comes out to about 9. So if we assume that we're pretty regular, if we divide by 9, that gives us a rate of 167. So right in that range of being SVT or V-Tach. Like, it could be either one. We will say that this is regular. I don't have any ectopy, other than the whole rhythm may be ectopy, and I don't have any pattern that jumps out. Do I have P waves? In the truest sense, no. I have little things here that I might be able to say was a P wave or something weird like that that could be affecting the rhythm. Heck, maybe even that one. But nothing that I can say is directly involved. So I can say no and wonder about AV dissociation, in that the P waves are occurring, but they're not what's going on. It could be a number of different things. Because of that, I really can't get a PRI done at all, which then leaves us with the QRSs. What can I learn from those? Well, I can say for certain they are essentially uniform. They are tall. They appear to be wide, although that's not very specific. They have an R prime shape to them. And it looks like my T wave is inverse. And if I go ahead and try and get a measurement on these, I like this one here because it's right near the start of a big line. I could probably go over a little bit. And I'm going to say that this is my J point here. So I've got 1, 2, right at about 3, which really doesn't help me at all either. Which is essentially normal, but also on the borderline of being either a bundle branch block or a wide QRS. And that really kind of leaves us still in a bit of a limbo, right? And ultimately, this is what then matters, right? Do they have a pulse? Are they symptomatic? What's their level of conscious? Their vital signs? Those are really what's kind of driving us at this point. Other things I can do to try and help myself out is, and physicians ask for this all the time. Can we get a baseline ECG? Do they have one in the past that we can compare it to? Because we're looking to see, did they have a bundle branch block beforehand? Maybe some kind of interventricular conduction delay. Other things, we try and get a new 12 lead done so that we can, take mark of what we have going on here. We check labs, we check meds, do they have a high potassium? Do they have coronary artery disease? What's their medical history? Are they on any anti-arrhythmics? All these are things that we need to help us figure out what's going on. I personally believe that in this case, this one's an SVT with aberrancy, if I remember correctly. But again, it'd be up for a real good debate as to what exactly is going on in this case. Your patient started the shift with rhythm A. Later, the alarms sound and you see rhythm B. What action would be most appropriate? So your patient early in the shift had this 5-beat run of PVCs, right? Technically V-Tach. And assuming you notified the nurse and they've already worked them up and whatever. But if later on in the shift you're now seeing something that's along this line, which is, for all intents and purposes, a continuous run of V-Tach, how emergent do you consider that to be? Well, it's not a false alarm. You wouldn't have a CNA go look at this patient. This is something that the primary nurse definitely needs to get in there. That being said, we won't say that this is non-emergent, but you have to decide, is this something that is worth calling an RRT, having the ICU nurses know first, and then calling that primary nurse, or do you just have the primary nurse handle it? Well, for me, I really do believe that this is that high-end emergency that you need to call the RRT, have the ICU nurses notified first, and then of course contacting the primary nurse as well about what's going on. When providing care to patients with the following rhythm, which of the following are priorities? So just looking at this without even figuring out what it is exactly, you can tell that it's tachycardic. And so whenever a patient has a rhythm that's going this fast, which you can go through and figure out, you're running the risk of having a decreased cardiac output. And that's what's going to drive your cares. So you get in the room, what do you do for that patient? Whether this is V-Tach, it could be SVT, you need to visualize the patient. Absolutely, you have to go in the room. You need to check for a pulse, one of the first things. You're going to collect vital signs if you can. If there's no pulse, initiate CPR if necessary. You do want to try and confirm if they're DNR, DNI status, that way we don't go down the wrong pathway. Are you going to ambulate them to the restroom with a rhythm like this? No, absolutely not, so we can cross that off. You're going to check level of consciousness, and that's part of your visualization of the patient, because if they have a pulse, hopefully they'll still be conscious. Are you going to move them from the floor to the bed immediately? No, you're not going to. You're going to, if they've had a syncopal event, they're on the floor, just make the scene safe, get the job done there, then worry about moving them when there's enough assistance available to do something like that. So just like before, ambulation, moving the patient, that's not the priorities. Mechanism of idioventricular rhythm. Another way to look at it is you can get rid of that I and just call it ventricular rhythm. The idea is this, that it occurs when there is a failure, a total failure of the SA node and the AV junction. They're both completely out, non-functional whatsoever. And what happens is a single escape focus within the ventricle fires up, and it just clips along at its inherent ventricular rate, which is really slow, and like 20 to 40 beats per minute slow. And so think about it, you don't have any sinus beats, you don't have any junctional beats, you just have ventricular beats going on at a really slow rate. And because it's happening outside the normal conduction system, you have that cell to cell, which gives you the wide QRS and the inverse T waves that go with that. It really looks like, the best way I can phrase it is to call it a PVC rhythm. That's regular. And when we take a look at these, you'll totally understand what I'm saying. But again, this is an escape mechanism. It's that last-ditch effort to try and keep the organism alive. All right, we are slow for sure. It can even drop below 20 depending on how bad the situation is. It's going to be really regular though. You'd be pretty impressed with that part. You're not going to have any P waves, no PRI. Your QRS will be wide. It will be bizarre. The T waves are going to be in the opposite direction, so inverse. And you're going to have that wide QRS, greater than 0.12 seconds. Now, I will make this quick side note that if you do see P waves, or another way to phrase it would be this, that the ventricular rhythms, particularly ventricular escape, ventricular escape is that rhythm that will occur when you're having a third degree AVB, or complete heart block. And that makes sense, right? And we went through that with our third degree stuff, that ventricular rhythms are the escape, are one of the escape options in that case. So do keep in mind, if you do see any P waves or a PRI, it's going to follow the same rules as third degree AVB does. We'll label these the same way we always do. And of course this strip is 6 seconds, but 4 times 10 gives us 40. We are definitely regular. Slow, there's no ectopy, and no pattern. It's all just marching out pretty nice. If we go ahead and do measurements from about right here, that comes out to 35. If we measure the other one just to be on the safe side, it comes out to about 33. So pretty close to one another. And that's one of the things about these slow rhythms is they can be a little bit more variable in this regard, but ultimately it doesn't change things by much, because you'll see our heart rates are 43 and 45, so not making a big difference. And I'll just say this right now, they're bradycardic. Do you think they're symptomatic? Yes, this rhythm is symptomatic. Anytime you see a heart rate in the 40s on screen, you should always ask the question of, how does this patient look? And want to get in there and try and make sure they're feeling okay and do that kind of workup. All right, now that I'm off that, I don't have anything that looks like a P wave, so I'm not going to be able to do a PRI. In terms of the QRS, what I can do, I can say that they are uniform. I've got an RS pattern. My T wave is inverse, what I can make of it. And we are wide. How wide is wide? Well, we'll start measuring right here. And I'm going to say that this is my J point, where it comes sharp and then goes horizontal. That little corner there, which marches up to about this spot. 1, 2, 3, 4, 5. Oops, sorry. 5 times 0.04 equals 0.20, which, just like we said, is wide. So I have a slow, regular, wide QRS, no P waves rhythm. Ventricular rhythm. Sorry, ventricular escape. And I tend to use those interchangeably. The idioventricular rhythm and ventricular escape. Essentially come down to the same concepts and things, in that the higher parts of the heart are not functioning, and that it is the ventricles creating what rhythm you have. And so I wouldn't dock anyone for trying to use those interchangeably, but keep in mind that they are talking about the same thing. Other fun fact, I'll just kind of wrap up real quick with this one and say that this is from another Comfort Cares patient. We withdrew life support over the course of a few minutes. The patient quickly declined. This is what immediately followed a burst of polymorphic V-Tach. They were tachycardic, and then they did a run of V-Tach for about 30-40 seconds, and then dropped into this rhythm for about a minute or two. and shortly thereafter they went into asystole. I point this out, I bring these forward, and I just want to say to you guys that it is very beneficial when you can find the opportunity to look at strips like these that represent what a dying heart looks like. You know, what happens when a heart ceases to function normally. Because then what that's going to do is help you identify rhythms faster and improve your judgment and reaction time, so that when something like this happens suddenly, you can immediately go, I know exactly why that's not good, and then be able to intervene more quickly. Here we have another one. And again, if you see a rate like this on the screen, you just need to go ahead and check the patient. You know, are they symptomatic? And I'd be shocked if they weren't, because this is a heart rate of 1, 2, 3, because that is a long strip. So you've got a heart rate of 30. And we are regular, we're wide, no pattern, no ectopy. I do not have any P waves, I do not have a PRI. The QRS are uniform. They have RS pattern to them. I'm actually going to make that a lowercase r. RS pattern. T-wave is inverse. We are wide. How wide is wide? And honestly, beat number 3 is the best one to measure. And we have a pretty clear ST, or a J point there, so we're 5 across. So at 0.20, it meets all those criteria of being slow, wide QRS, inverse T wave, very regular, and no P waves. Idioventricular. And again, if they're symptomatic, which I would be shocked if they weren't, you're going to do the ACLS, bradycardia, possibly compressions, and be ready to do a pacemaker of some kind to assist them. So why do we care about idioventricular rhythm? Why are we bothering? Well, it carries a pretty poor prognosis, and that makes sense, right? It's that last effort to pump blood by the heart. So last effort to pump blood by the heart. It's a late stage type of thing that can happen. Or only happens when you've had this cascade of failures throughout the heart with the sinus node and the AV node. You know, and if you're in 3rd degree AVB, you may see this type of rhythm pop up as well, which is also a rather dangerous rhythm to be in. If the patient isn't clinically dead by that point with such a low heart rate, and if their BP has dropped accordingly, if they haven't passed away, they're awful close to it, which means you need to intervene. Intervene with ACLS as quickly as you possibly can. because that's what will make the difference between them continuing to decline or hopefully improving. And just the quick one is going to be compressions. Get ready to do pacer, either with the pads on or temporary wire. And you may do drugs like dopamine to try and see if that makes a difference or not. Ultimately, the triggers, you know, it's ischemia, so an MI or just excessively low oxygen, you know, if it's a respiratory being the initial cause. Large infarcts will do it, really bad AV blocks, particularly third degree, and medications that can mess with all that stuff too. I'm revisiting this one because it fits well here. We already touched on it in the blocks lecture, because the idea is the sinus node is still creating impulses, but the AV node is failing to conduct, so no atrial impulses reach the ventricle, so you have AV dissociation. And what that causes is you just have a series of P waves and nothing else, which is why it makes sense to call it ventricular standstill, because the ventricles have stopped. But yeah, you have a total block going on between these, which may be familiar because that is a third degree AVB, or complete heart block, without an escape rhythm going on. And we had just talked about idioventricular rhythms or ventricular escape and how that would tack on to this very easily. I'll said it before and I'll say it again. Check the patient. Compressions, because I'm going to guess you won't find a pulse with this one. Mark these off real quick. 1, 2, 3, 4, 5, and 6. But that is just the atrial rate, because the ventricular rate is absolutely 0. There are no QRSs to be found on here whatsoever. No QRSs, no Ectopy. All right, so we have that. We have great P waves. They are upright, uniform. I have 1 P for no QRSs. They are regular. You can kind of eyeball it to see that they are. But if we go ahead and measure these out, I really don't think there's a good pair to measure between. Comes out to about 25, and that marks out accordingly. If we look at our PRI, there is no QRS equals no PRI. And we've got a none there. So that really just leaves us with ventricular standstill. Without escape rhythm. Ultimately, with your interventions, you're going to need pads to pace them with. and might wind up being reasonably successful doing so. But this is a stat scenario. There is no blood movement whatsoever. And call that the sudden cardiac arrest. Which statements about idioventricular rhythm and ventricular standstill are correct? And this really is just going through the rules and learning, how we classify these. So first off, IVR impulses originate in the ventricles. That's the definition of idioventricular, right? Ventricular standstill, impulses originate in the ventricles. That's not true. In fact, there is nothing coming from the ventricles, so that one's not accurate. Idioventricular rhythm is an escape rhythm that can occur when a higher pacemaker fails. That's really kind of the definition of idioventricular, or usually the cause of when it occurs. Last but not least, ventricular standstill occurs when the atria function normally, but there is no conduction to the ventricles. That is the definition of ventricular standstill. So there's your answers. Your patient started the shift with rhythm A. Later on, the battery empty alarm sounds and you see rhythm B. And the question is, which action is most appropriate? Well, they started out in AFib with SVR, slow ventricular response. And now all you see is asystole on the monitor. And you have to decide how aggressive to be in terms of getting this corrected, because you don't have telemetry. You don't know if the patient is in asystole or not, because the telemetry is not sending any signal back. So I'd automatically discount this as being non-emergent. While if there's enough lead time, a low battery alarm is non-emergent, but the battery's gone completely empty. So now you have to decide, is this something urgent that you just really push for the CNA or the RN to change it immediately? Is this emergent enough to call an RRT? No, because likely it's due to the battery being empty is why you see asystole on the monitors. I would honestly say that this is something that's emergent enough that contacting that primary nurse immediately is your course of action, and to definitely escalate if unable to contact them. Call the CNA as well, call the charge nurse. Really push to get that battery changed as soon as possible, because that's what you need in order to do the job as well as you can. So this is emergent enough to really push to get it changed as quickly as possible. The telemetry tech notifies you that your patient's battery empty alarm has sounded, creating a systole on the monitor. What first action would be most appropriate? And so you have to decide, is that monitor tech really does not know what your patient's heart rhythm is doing now? Is this a case where it's non-emergent and there's no reason to hurry? Is it urgent, where someone needs to get in there and change it as quickly as possible? Or is it emergent, where you need to call an RRT or something at that level? Well, I'm going to take non-emergent off as a choice because we have asystole. The patient's on a monitor for a reason. We need to be able to see that heart rhythm. So this is a little bit higher end, and so you have to decide, is this an urgent matter or is it just emergent? Well, the monitor tech has likely contacted that primary nurse immediately and is really pushing to escalate if it doesn't get corrected soon. So for you as the nurse at the bedside or the CNA, whoever it may be, this is definitely an urgent matter. It doesn't matter who does it, but that battery needs to be changed as soon as possible.